failure, or if they're having heart attack, have coronary blockage, have a bad valve. So echocardiography is really a very helpful tool in general.
Mitral valve. I agree with you again on that. It's a way that, if they had a wall motion and you were suspect that something was going on with a blockage in the heart artery, just give you a lot more information as well, too. We're just now looking back, we've already looked at some of these structures, but just a different view, and that's the mitral valve that colors on there, and you see that valve kind of flipping in and out there. Blood's pumping. As you see that top part squeezing, it's ejecting blood through that valve. We're back the other way, and you can't see the aortic valve right now, but we're looking for color leak in the opposite way, and there's really none. You can take me off color if you want there, Jessica.
Yeah, it's really a beautiful study of normal heart other than one valve, looks like.
Absolutely, and there's the tricuspid valve. So again, that valve that's on the right side of the heart, and this image is a really good image to get too. Sometimes you can't see this valve that well up top, and you come down here and you can absolutely see it. We'll put some color across that.
Is that a right atrial appendage down there?
That is. That actually is a right atrial appendage. We looked at the left atrial appendage earlier, and the right atrial appendage is down in the bottom part of your screen. Again, probably not as well looked at. Hard to see, actually, in most patients. And this young lady's got great images for us to look at. But again, another place for potential blood clot to form. Again, no leakage through that tricuspid valve there either. Right. We're going to go off color here, and basically I'm going to, actually right there I can just kind of show you a little bit. To the left there you see a structure that looks a little bit more dense. It's got a little bit of black spots it would look like in it, and that's actually a normal appearing liver. And from where you are looking back up, the heart's over there on the right and the liver's there on the left, just to kind of give you some structures there.
What if you had a pericardial effusion or fluid around the heart? What would happen there?
Let me just grab a little bit of a view here. And
pericardial effusion is what we call fluid around the heart, in the heart sac. It surrounds the heart.
That's exactly right. And I'm going to, basically, I think this is a pretty good view because there's the heart right there, a little bit smaller. Again, you see the pumping chamber, which is the left ventricle on your right, the right ventricle over on your left, actually, and then the liver on top of it. You would typically, if they had an effusion, you'd see a dark black space all the way around there from where the liver is and all the way around the heart. It looked like it was encased in a black circle. And that would be a pericardial effusion or a lot of fluid. And we all have some fluid around the heart. It's kind of protective, but you don't want a lot, basically. At this
What happens if you get a lot of fluid?
If you get a lot of fluid, then it constricts actually the way the heart relaxes, which is a little bit different than squeezing. But if the heart can't relax normally except the blood flow that's coming to it, at that point, you basically have some problems with pressure, and you can't get the volume or pressure over to the left side to pump out, and people have a lot of problems with their blood pressures. And actually an emergent situation, short of breath, swelling, emergent situation in most situations where we actually, in the catheterization lab, stick a needle through the chest wall into that space, which we do under actually regular echocardiography with ultrasound, and drain that fluid off for people. It can be a life-saving procedure.
Do they ever do these procedures during heart surgery, Jeff?
They do. A lot of times, like, not in this young lady, but say that valve that we looked at, that aortic valve needed to be replaced, which is not the case here at all, but in patients that it did, it's a good way to put the probe down during the surgery, after they get surgery done, before they take the patients off what they call the heart-lung bypass machine. Good opportunity to basically look and make sure the work that you've done has worked well and that valve is doing okay.
Before they close them up, they can double check,
Absolutely.
right?
I mean, the worst thing you want to do is put a new valve or repair a valve and go ahead and close somebody up, and then your repair is really not as good as you wanted it to be. So I can tell you from experience, I have a family member who's had a mitral valve done, and actually that was the situation. They did the valve, tried to repair it, spent 3 hours trying to repair the valve, could not get the valve repaired, and then actually said, you know what, these images aren't good enough. We're not closing up. We're just going to put a new valve in.
Right.
So very helpful in that situation.
Very good.
I think we're coming to the end here. I'm going to look at one more structure, which is actually...
You want to look at the aorta coming out?
I am.
Okay. Go ahead, Jeff.
You know what? I'm going to try... Let me just... One more image down here.
Okay.
And Jessica, who is my great echo tech.
She's doing a good job flipping the switches, isn't she?
She is. She reminded me a little bit.
All these tests depend on the technicians. I mean, the doctors do some of the work, but I'll tell you, the behind-the-scenes work by the nurses and technicians in all hospitals is maybe a lot more gets appreciated. This is a question.
We're just going to get some more pictures here.
Jeff, I have a question here, and it's a good one. It says, what kind of sedation do you use for this procedure?
We give patients medicines called Versed and fentanyl, both of which Versed has some amnesic effect and makes patients comfortable. Fentanyl is a pain medication, and in combination, typically, keep people really relaxed and comfortable doing this procedure. So dosage for that's dependent on all the patients.
Right.
A little bit or a lot, just depends on what you're used to a little bit. I think we're going to go ahead and finish up.
How long do we usually keep these people in after we finish up here?
Typically watch them for around an hour or so is about all we need to. Can't drive that day after you have the procedure done. I also tell patients you shouldn't be making any business decisions that day as well, too. But, somebody needs to drive you home, need to take it easy during that time, and typically a lot of times you can feel like you're kind of just worn out and tired from having all the sedation.
Can you get the aorta there? Or
I am. We're going to take a little look here, and
this is sort of the last segment, I think, of this study.
We're about done. A little artifact here. Let's see. Maybe about as good as we get right up there.
Okay, that looks good.
But the aorta looks good. And
this is a descending thoracic aorta.
Exactly right.
Which is coming out of the heart and circles around and goes down the back towards the abdomen and the legs. So we're going to be talking about actually the aorta in a minute here. So that's a little, you can see it's a rather large round structure there that carries all the blood out from the heart to the rest of the body. So it's, of course, a very important thing to visualize. And with TEE, he didn't get to show it too much at that point, but with TEE we can sometimes see blood clots as well as a plaque and other abnormalities of the aorta, which are really important to know about. That was a great job.
Oh, thank you.
Everything going there okay?
Everything's doing great. Patient's doing great.
Well?
She's already waking up, and we're going to kind of...
So you're going to go talk to the family, keep an eye on the patient for a few minutes, make sure everything's okay, and then you're going to rejoin us in that room there, and we'll be asking you some questions and
I'll join you back.
Stump the expert.
That'd be perfectly fine. I'll be back in a few minutes. I'm going to go talk to family and make sure this young lady's doing okay and get her back with her family. Then I'll rejoin you in a few minutes.
Okay. Well, thanks for a job well done there.
Thank you.
Appreciate it.
Absolutely.
And we especially appreciate the patient and the patient's family for proceeding with this. We really do. Shawnee Mission really appreciates you helping us out with this telecast tonight, or netcast. Anyway, we're going to switch gears a little bit. Our center is concerned about all aspects of vascular care, cardiac and peripheral vascular. And tonight we started out with a cardiac portion of our care, a transesophageal echocardiogram. We also have a very active cardiac cath lab, which we do cardiac caths, angioplasties, coronary stents, and other cardiac procedures. And we're going to actually have a whole hour tomorrow night and another webcast to go over this sort of thing. So tonight we're going to switch from the heart a little bit, and we're going to join our panelists here and talk more about peripheral vascular disease, and then also about general treatment of vascular disease. And we'll be glad to answer any questions you might have, and you can send these in live as we're talking. I'll be glad to address them as they come up. First of all, I'm going to ask Dr. Mike Beasley about aorta disease, abdominal aortic aneurysms, which are a common problem we run into, and if you could tell us what that is. We saw the aorta a little bit, didn't see it all the way down to the abdomen, but we saw it going towards the abdomen. If you could just tell us a little bit about what happens when you have abdominal aortic aneurysm and what the best treatment is, that sort of thing.
I'd be glad to. Arterial aneurysmal disease is a gradual weakness of the artery, which, if undetected over time, can enlarge to a point where the artery actually could leak or rupture or bleed internally, and that could be a life-threatening situation. The most common place for that to occur is in the abdominal part of the aorta, just below the kidney arteries. These are fairly common in that aneurysmal disease of the abdominal aorta occurs in about 2% of the population. And Medicare nowadays allows an initial ultrasound screening after age 55 to detect these things, because if not detected from an ultrasound or a CT scan or x-rays done for some other reason, then they can go undetected very easily.
And if they don't get detected, what happens in the end?
Well, if they continue to enlarge and leak and bleed, then most people either die immediately or can barely make it to the hospital. We want to catch them early, because
too late is too late.
That's right. It's about still a 50-50 chance of making it once a person hits the emergency room with a leaking abdominal aneurysm. The traditional treatment for elective repair of aneurysmal disease has been the open technique, obviously through a large, long midline abdominal incision. That's been the traditional treatment since the 50s. It's still probably the best treatment in that it definitively takes care of